Good morning. So we'll have this class with an illustration of cases for central venous disease and how do we approach it on a practical basis. I have nothing to disclose. So the outline of the talk would be when to suspect central venous stenosis, then how will you, if you suspect, how will you evaluate it, how will you assess the severity of obstruction, how to decide on lesions which require intervention, when to abandon the access by tying the AV fistula, when can a nephrologist attempt to intervene safely without any other assistance once he has acquired the skills to do it. And there will be certain video demonstrations of illustrative cases on the way as the talk goes on. So we start with a question. So have you ever seen a patient with thoracic venous obstruction that confounds the passage of catheter or causes swelling or other symptoms? Obvious answer is yes. All of us have had in the beginning or even now cases, or when we were doing it, you attempt to put a temporary catheter and suddenly you find that the gadwall is getting obstructed, and then subsequently you find that there is in a central venous stenosis. That's a very, very common occurrence. So we have to define central veins, and central veins can be both defined in the upper limbs as well as in the lower limbs. But for the purpose of this talk, we will be only concentrating on the upper limb, and that's how we define the central veins here. It starts with the thoracic inlet up to the first rib on this side, and the similar thing on the other side. So this is how you identify it, and the subclavian vein, which begins at the lateral part of the first rib, and the axillary vein are not part of the central venous system. And then when we talk about central venous stenosis, we have had experience of seeing various kinds of hands with fistula and having problems. And I'm sure all of you would have seen that. So have you seen this kind of hand, severe central venous stenosis? Or if you see this kind of hand, but when you examine the full hand, it is just the palm which is got a problem and not the rest of the hand. So this is different from the first case. This is probably central venous stenosis. This is venous hypertension. Or if you see this kind of vein with a lot of collaterals, or if you see this which is all the way dilated, or again distal ischemia symptoms, scar which is just not healed and no veins visible here. So these are the different kinds of arms which we see. So this is another one with working fistula, but with an ulceration, blackness, and dilated veins seen all the way up there. And this is the problem. Probably there is a central venous stenosis here, or this kind of problems where there has been aneurysmal dilatation. So various problems occur. So let me start with this case. So this is very old case, and this was when in the era where subclavian vein dialysis catheters, non-tunnel, were used, and patient also happened to have a right radiocephalic fistula, and patient started having the swelling since 2005. At that time, patient was on dialysis, subclavian venoplasty with stenting was done, and AV fistula worked in 2019 when he had a cadaver renal transplant. So post-renal transplant, he came with this kind of hand. And what happened was that he had a stent fracture. So there was a narrowing again in the subclavian vein. So what was done was, after having passed the wire, in-stent plasty was done, and a stent was inserted within the stent. Over a period of 1 month, if you see and compare it with previous picture, the hand started regressing, and subsequently it became almost normal. And that was the time at which he was advised to undergo surgical ligation of AV fistula, though he was given a choice of endovascular occlusion, but he could not afford it further. So this was an abstract which was presented at ASN way back, and yes, what we found is that subclavian catheters are associated with high risk of central venous stenosis. Hence, we should never use subclavian vein unless there is no other option. And he had this in an era when this was not a recommendation. Also, stenting was not supposed to be done. In the present time, it is not a preferred method, but in those days, stenting was supposed to be the first method of choice. And what happened? The stent, because it was lying in the subclavian vein, then with the movement of the hand, etc., the friction, compression of the stent between the first rib and the clavicle, it subsequently fractured. There was a venous congestion, and so much so that we would have thought that he would lose his right upper limb if we don't do any intervention. So whenever we suspect that there is a central venous stenosis or otherwise when there are problems, we have to have cost examination. The basic principle of look, listen and feel remains. So you look for such kind of issues. You inspect for central venous stenosis, you see dilated tortuous veins or unequal swelling between the two arms, or you look for signs of ischemia distally like this. So inspection is basic part of the problem to begin with, to evaluate and come further. And then there are two more. So look, listen, feel are the three tests one would do. And along with that, there is an augmentation test, and then there is an arm raising test. So these five constitute what one would call as 1 minute evaluation of a fistula. So of these, let us go through this video to see what is the arm raising test. And suppose this is the fistula, a question arises, are these aneurysmal, venous aneurysmal dilatations problematic or they are okay and you can live with it? For that, you need to do the simple test, what we call as arm raising test, and see what happens. Just concentrate the vein and then it just collapse, totally collapse. That means the venous drainage. Can you see the video?
Yes.
But you want to start my video? Okay, 1 minute. Where is my video?
सर आप अपना वीडियो ऑन कर
Yes. That's what. How do I do that?
thank
That's
you,
what
sir.
I'm trying to do. It shows stop video. Okay. I've started my video. Can you do it, Ruchi, over on your side?
No, so you have to do it by your end.
No, but
Beside your mute option.
I think we could see the video when you first demonstrated. Maybe we should go further.
You could see this video.
Yes, we could see.
Yes.
You want to start my video, right? So this is how you see the collapse of the vein, and when you bring the arm back, again the veins are nicely refilling. This is the study which you will do very easy for a bedside evaluation of clear venous outflow from the body of the AV fistula right all the way to the central vein. So this is the arm raising test which one can do, and then we come to this question as to how does central venous stenosis occur, and this could be related to certain devices like central lines of various kind, whether it's the CVP line for ICU purpose, tunnel catheter, non-tunnel catheters, PIC lines, dialysis, cardiac rhythm devices, etc. But it could be unrelated to intravascular device. It could be idiopathic, extrinsic compression of the vein, dialysis associated venous thoracic outlet syndrome and various other reasons. Now, what happens in dialysis patients? The high venous pressure and blood flow due to the fistula may overwhelm the collateral venous and lymphatic drainage, resulting in the development of dilated and tortuous collateral veins over the ipsilateral upper arm, neck, and upper chest. In severe cases, venous hypertension may eventually lead to disabling arm edema with pain and discomfort. Endothelial injury with subsequent changes in the vessel wall results in the development of microthrombi, smooth muscle proliferation, and central venous stenosis. So this is the physiology by which you get. And then, as we said, there are various factors which can precipitate it, and most of the time, with past history of a central line of any kind, patients are asymptomatic. It is only in the event when a fistula is made, and then the whole thing gets unmasked, and then there is development of ipsilateral edema, breast engorgement, etc. And then when you go back to the history, patient will tell you, oh yes, 5 years ago I was in the ICU and I had a central line. Something of that sort of history is something which you keep on getting very, very repeatedly. So for a busy nephrologist, what should be done? So one is, it's a very good habit to have examination of AV fistula and AV fistula arm by staff. So educate your staff. If they cannot do it on everyday basis, every dialysis basis, they should do it on a weekly basis. If you have a vascular access coordinator, it is good, but whoever suspects should refer to the nephrologist for appropriate intervention. Diagnosis is based on history, physical examination, and then if you suspect it further, then you can suggest ultrasound, duplex ultrasound, which will show absence of normal respiratory variation with the diameter of central veins, polyphasic atrial waves. You can't visualize central veins with duplex ultrasound, but my suggestion is if there is a very strong clinical suspicion of a central venous stenosis, there is no point in wasting time, money, and energy on doing this duplex ultrasound, and one should be subjected straight away to conventional DSA, which will be diagnostic, and then if need be, also do therapeutic intervention. However, one must remember that not all central vein problems are due to endorenal pathology. So there could be presence of collaterals, there could be stenotic lesions which occur at the junction of the first rib and the clavicle. And then it is very important to recognize the external compression, because if you dilate the vein in that situation, then you are obviously the failure. But there are certain situations where you need to go beyond Doppler and choose either between computerized tomography, venography phase, or you can do an MR. And I'll give you one example of each. When you need to have a proper diagnosis, or what we call as appropriate venous mapping with a past history of recurrent multiple bilateral catheterization and patient coming with swollen arm, it becomes very, very important that we have to have a venous mapping with the help of some modality, so as to not only establish the diagnosis but also to plan appropriate intervention. So this is how it is. So this patient came with breathlessness and at rest and intradialytic hypotension of recent onset, and she was told to have coronary artery disease because she was a diabetic and she was being prepared for transplant at another center. She came to us, so we saw all these things. She had dilated tortuous veins, so diagnosis was somehow patient landed up with cardiologist, coronary angio was done, which was dying normal. So then patient was referred to us and we said we'll do a CT to find out what it is and see what has happened. So you see this thrombus here at the tip, which Dr. Khanna is going to discuss further on, but I would like you to concentrate on this same patient's picture. So what has happened is that this patient, if you see all these collateral veins, means she has chronically obstructed central vein somewhere here. And if you see this thrombus around the catheter tip, That's something which appears acute, and that's why there is now acute dysfunction of the catheter. So this could be accurately diagnosed, and then subsequently you would obviously plan accordingly. As opposed to that, there are many situations, including lack of vascular access, because most of the time the CT people want to inject the dye fast, and they need a cannula of at least 20 gauge or 18 gauge to be able to do that. And many a times our patients don't have that kind of a vein. So in such a situation, we have resorted to MR venography, and that's done with a time of flight protocol, no gadolinium, and see how excellent the results are. So if you see it on the left side, this is the MR venography of the central veins. Now look at the left IJV. You see some stenosis here. This is then with knowing this. So obviously, if you look at it right side, you would not probably like to attempt because there is nothing visible either in the form of IJV or EJV. But over here, this is good. There's a stenosis here. So we punctured it here. This is correlated here. There is a stenosis. We did a plasty, and we could easily put a tunnel dialysis catheter. So in such situation, planning and evaluating with some modality like CT or MRI will be of definite. And then once you diagnose it, what are your options? You obviously will consider angioplasty, with stenting for failed angioplasty, whether you would use stent grafts, whether you will consider primary stenting, and then lastly, whether this is the problem at the central vein level, or whether it is a high flowing fistula and you will do assisted bending or some other surgical flow reduction technique. So that also has to be remembered, that all central vein stenosis problems need not be tackled at the central level. You have to also look at the peripheral level sometimes. So this could be probably known by doing a Doppler study before intervening in such a situation. So let's take the example of this case, which was presented at ASDIN meeting in form of a video. So I would like you to go through it. So this is a patient who developed central venous stenosis with various other problems, and so it came with ipsilateral limb edema, hemifacial swelling, diminished vision, decreased hearing on the right side, throbbing headache, and this was 1 year after undergoing fistula. So this is his arm, and through this arm, they are puncturing him here, and they are puncturing him here, and if you see hemifacial swelling, ptosis, etc., yes, diminished vision. You see this dilated veins over the chest. So this is the problem with which he came. We did a Doppler, so there were abnormal waveforms in the jugular or subclavian vein, and that should prompt further evaluation. So patient was subjected to angioplasty. Aim was to study whole arterial and venous circuit in this situation. So we came with the femoral arterial route, and this was fine. So this was followed by the study of the fistula, and we found that this was a high flow fistula. Then we punctured the femoral vein and came all the way up there. And then there was this stenotic segment which was bypassed. Then if you see, there is a retrograde flow still in the veins up in the neck because of the stenosis here. So look at the shouldering on the balloon, which is suggestive that how now this has opened up. And now if you check the do it, still not a very satisfying result. So you would like to go in again with large size balloon, and again you are able to dilate it completely. Again you do check angio. Still the result is not very satisfactory. So, but if you see, the collaterals have reduced. So this is the time when you put a stent, and this is how the stent is deployed. So a long stent, The most important thing you have to realize is that the brachiocephalic vein is coming to left side and don't jail it. If you do that, then in case you want to put a left sided tunnel catheter, you would have blocked the vein. So that has to be measured accurately. Once that is done, you do again a check angio and always do instant plastic at least once again. So that's done to assure that stent is patent, and then this is the final picture. So that's how, see, within few days, hand has become normal, facial swelling has gone, the redness of the chest has gone. So patient is happy, we are happy, the fistula. You can see the dilated vein here. This could be used for the purpose of dialysis. So stenting for central venous stenosis is appropriate only when there is an elastic recoil of more than 50% following angioplasty, and if there is recurrent stenosis within a 3-month period of angioplasty. Now the question is, can nephrologist do it, or you need some assistance? With basic training, simple cases can be definitely tackled by the nephrologist. You don't need very sophisticated setup. You need the basic. The basic items required has already been addressed to, and if there is a basic training in interventional nephrology, if you have access to cath lab, that's better. But for the insertion of tunnel catheter CAPD, even a CM should be okay. If you have an interventional radiologist, excellent. But if you're not, most of the centers now and cities now have interventional cardiologists. And to begin with, you can take help of cardiologists. They will be more than happy to assist you in this. So if this was a simple case, can the nephrologist do it? So this lady came with right upper arm swelling. And if you find that the cephalic arch and there is a stenosis at the junction here, so you're able to pass the wire. You do a plasty here, very easily doable. This is not a very difficult case. So if you see it again here, you're doing the plasty, and then yes, that's done, and then you have this narrowing has gone. So this is a simple case, which is nephrology. Or this lady had a right IJV TCC. She came with malfunctioning catheter. So after catheter pull back, we did a shoot. The tip was lying just here at the time point at which there is a SVCRA junction narrowing. So wire is passed all the way down, and then plasty is done. See, this is the narrowing here. You are able to dilate it completely, and then once done, you put a catheter. It's right in the right atrium. You can see nice outflow, and this is how you can tackle central venous stenosis at a simple level as nephrologist. But what to do if you have something which is complicated, which needs more planning? So a 60-year-old male, right brachiocephalic fistula, right arm swelling. Hemodialysis initiated earlier with right IJV non-cuffed catheter 6 months ago, removed after 2 months. He is right-handed, disabled, he's got right arm swelling, his AV fistula has a blood flow of 1250 for a brachiocephalic AV fistula, and he's still being used, so the cannulation is difficult. And swelling has worsened over past 3 months. He can no longer use his arm to do day-to-day things. So this is the angiography, complete obstruction here, and what would one do in such a situation? So what is the first attempt to treat this patient's problem? For this type of chronic occlusion, plan would be to cross, and if necessary, well, as a stand. That could be one option. How will you approach from the upper arm? If this strategy fail, I would like to access the right common femoral vein and advance. So in such a situation, when you just don't know, what one would do is what is called as access and groin approach, which means you put one needle through the access vein in the right or left arm or forearm, as the case may be, because those veins are easily accessible, and you also go through the groin. You simultaneously advance your wires and catheters into a situation where you are able to take simultaneous shoot, try and cross if possible, and then you will try to do angioplasty if possible. If that requires, then you will do balloon expandable covered stent. But as I said earlier, don't change the left brachiocephalic vein when you're tackling the right brachiocephalic vein. And also consider decompressing the outlet with clavicle removal or first rib dissection in certain given situations. So you have three options. You do an angioplasty. I mean, not that you do everything in all the patients. You also consider decompressing it surgically, and you also consider reducing the flow of the fistula either again surgically or with balloon assisted bending, etc. So if this fails, then one of the options would be to insert TCC and close the right brachiocephalic fistula and plan for a left-sided AV fistula. So that also sometimes has to be done in given situation. And if the second option fails, and if the venous hypertension persists despite flow reduction, then you would ligate and fistula surgically or endovascularly, plan for the access on the other. But prior to that, you can have these two options. So if there is a CTO, then these are the two new things. Zero, of course, is not very new. So this is a hybrid where you have central venous catheter going right up to the right atrium, and then there is this connection, and then there is this graft component which is then attached to the artery here. So this is a cannulable zone, and this can be used. So there is a internalized central catheter, so to say. The other thing which has recently come up is what is called as a surfacer inside out device. And this is how you do. You have a complete obstruction here. You go from femoral vein here. This is this device which is placed on the skin where you want the, and then through this vein there is this sharp needle. We go through and through the tissue here and come out in the neck. Once you come out, you pull it back, push the wire in, and then put a tunnel catheter. So this is the totally occluded vein, and you go from inside to out to puncture. Normally we puncture from outside to in, but this is a device which assists you to puncture it the other way around. So this is one option. And then when we deal with this type of thoracic central vein obstructions, Society of Interventional Radiology has got some reporting standards. This has been published by Bart Dolmage. Bart Dolmage is one of the course conductor of the controversies in dialysis access, which is held every year or two at Medanta Hospital group. So the way this has been otherwise approached has been empiric and with very inconsistent literature and different definitions and different outcome measures. So we needed some, so this is what we would call as type 1 CTO, and this is what we would call as type 2 CTO. To establish this central vein work group was established, and this included people from surgery, IR, cardiology, nephrology, etc. More than 20 people worked for 3 years to develop this criteria, and then there is this type 3 CTO. You see a azygous vein and a subclavian vein, which is occluded above at the level. I'll show you similar case in one of my patients later on. So there are these reporting standards by which you define these TCVOs as type 1, which can be then divided into type A, B, C, D. This article can be accessed here, and then there is type 2, which is here, E and F. Again, you call it 2A and 2B, or you call you have type B here, and then a type 3 here, and then you have SVC obstruction that prevents a direct thoracic venous outflow to the right atrium with any constellation of brachiocephalic, internotubular, or subclavian vein obstruction. So these are the ways in which one has to divide, because as I said, if you are going to do some venous mapping, then you will have to find out as to what sort of obstruction you are dealing with so that you can plan your therapy. And then when you report it, again, this has been standardized, so you have to report it with respect to anatomy, flow, symptoms, duration of symptoms, signs, performance status, whether patient has impairment or no impairment, anatomic pattern, and what is the impact on the patient care. So everything has to be reported. So this becomes very standardized method of reporting. And one of the major problem which is being found now, next to the repeated use of non-tunnel dialysis catheter, which are done multiple times and which has been emphasized by me and others on multiple occasions, that go for at least a tunnel catheter rather than resorting to multiple use of non-tunnel stiff catheters, which can predispose and increase the risk of central venous stenosis. It is the next one which is being recognized is the cardiovascular implantable electronic device. And again, this was a poster presentation in Atlanta last year. So this is one of the case I will show you. So this patient has a pacemaker and a tunnel catheter, and this has been malfunctioning. Okay, so and what you found is that there is a narrowing here. If you see, this catheter is malfunctioning because of that. So you keep the catheter in, see again, tight shouldering there, which means there is a tight stenosis, the another stenosis here. You try hard and hard and hard, keep on pressing. You have an inflation device, so you know what pressure what is your rated burst pressure, that is the pressure up to which you can go safely, with, in which case 99% of the times the balloon would not rupture. So see this shouldering again, and you make sure that around the tip the vein is patent, otherwise again there will be a problem. And you do a check angio. Are you happy? Maybe you are not yet happy. So you would then go in for further angioplasty, so that you want to be sure that this is like totally open. So second angioplasty. See how this has become more difficult. We have to struggle and struggle and struggle till we get this complete dilatation, and then see this final. You are happy now. The vein is absolutely normal. The tip is free from any obstruction, and this catheter will work in presence of cardiac rhythm delay. So this is the summary of the case. So when we did the first shoot, this is what I was telling you, that there is an obstruction here, and that's why the azygous vein is filling. Number one. Number two, this is something which is scary. You start seeing the pericardium. So why does the pericardium fill? Again, same thing, because your azygous vein and crosses the pericardium before entering into the SVC, and because there is a complete obstruction here, the through the sinus, the pericardium was getting filled. So if you see this kind of a film, just don't panic that you have punctured the heart or something of that sort. And then, as I said, we did all sorts of dilatations, and then we managed to get into this proper working up. So, in our conclusion, we said that when we talk about catheter avoidance surgery, but we are still left with TCCS, sole vascular access. Also, when pacemaker with epicardial leads and leadless pacemakers are available, why should cardiologists not be encouraged to prefer these over the conventional catheters with lead? If that happens, it is also possible to have coexistence of two lifelines. Even pacemaker leads are lifeline and dialysis catheter is also. But one should try and avoid such a situation, and try and have it on the contralateral side, convince the cardiac, because we have had several cases where patients have come and they had a pacemaker earlier and surgeon has made a fistula on the same side or the other way around. So this should be avoided. So this is the conventional pacemaker. This is one of our patients where we convinced the cardiologist and cardiac surgeon to put epicardial lead, and this is how leadless pacemaker would be placed, and so that your central veins in both these cases are kept open these were the cases with CKD, and this is how one has to approach the problem right upfront. And then every time you are not going to get success. So when there is a need for a vascular access and your central veins are not amenable to plasties and stenting, you can have surgical options. So there have been instances of brachial artery to tubular vein bypass graft or thickenous vein to loop transposition, superficial femoral vein transposition, axillary artery to popliteal vein bypass. If these also fail and the patient has a problem, then you will consider surgical closure of AV fistula. But you can also attempt endovascular closure, for which coils, glues, detachable and occluding balloons, and vascular plugs, MPLUGs vascular plugs are available. So just to complete the whole scenario, and before I leave and end this talk, for a future, we would be talking about two more things which are coming up in the central vein. One is, what is the role of drug-coated balloons in treating central veins? We are now getting the large size balloons, because as you know, central veins are larger than peripheral veins. So there have been a lot of studies about using drug-coated balloon in AV fistula plasty, but as far as central venous stenosis is concerned, there is something which we still need to await for the long-term result, number one. Number two, use of intravenous ultrasound for tackling central venous stenosis, as exemplified in this particular picture. So this is the ultrasound probe here, and if you see this, oh yes, you have done good plastic, but no, if you do the ultrasound, you still find some muck sitting there and some here, and then now you do proper plasty, and now you see that vein has got totally clear. So this is something which will have to be done. Hopefully, we will have more on this, but by next avatar, we should be able to do it. So thank you very much, and for all those who are interested, I've had two articles. These are the references. This is a chapter, and one can visit that. Thank you very much.